It strikes me that one of the most fundamental aspects of understanding a child is, well, recognizing when their development might be unfolding a little differently.
Hmm.
And that's precisely what we're diving into today. We're aiming for a focused discussion, actually. We've got some great material, a detailed medical chapter, and a really insightful YouTube video transcript.
Yeah, all focused on developmental delay and intellectual disability.
Exactly.
It's definitely a topic where getting clear information is so important. And, we want to be mindful of everyone's time as we unpack what can feel like complex info.
Right.
Our goal here is really just to pull out the most crucial bits from these sources for you.
Absolutely. So our mission for this deep dive is to clarify the definitions, how these conditions are diagnosed, what might cause them, and crucially, what kind of support is out there.
Hmm.
Think of this as your sort of personal guide, getting a clear, comprehensive picture without getting totally bogged down.
Thanks.
Okay, let's jump in efficiently. Starting with the basics, defining the terms. What exactly is intellectual disability?
Okay, so intellectual disability, or ID, it's really defined by a combination of things, not just one element. The sources are clear on this.
Okay.
It involves deficits in intellectual functioning, so that's things like reasoning, memory, learning from experience, problem solving.
Right, the cognitive side.
Exactly. And significant limitations in what we call adaptive behavior. That's key. Intellectual ability by itself isn't the whole story.
So how they function day to day.
Precisely. It's about functioning independently. And really importantly, these difficulties have to be present before the person reaches maturity. Generally, that's considered, before 18 to 22 years old.
Okay.
Oh, and it's worth mentioning the medical text points out that in Europe, they often use the term learning disability for what we typically call intellectual disability here.
Ah, interesting distinction. Okay, so it's not just about an IQ score.
Mhm.
This adaptive behavior piece sounds really critical. Can you break that down a bit more?
Definitely. Adaptive behavior, it refers to those everyday skills we all need, basically. Functioning at home, school, work, out in the community.
Right.
The AA, that's the American Association on Intellectual and Developmental Disabilities, and the DSM-5, they group these skills into three broad sets: conceptual, social, and practical.
Okay, conceptual, social, practical. Can you give us some examples?
Sure. Conceptual skills would be things like language understanding it, expressing yourself, reading, writing, grasping concepts like time and numbers, managing yourself.
Okay,
Social skills cover things like interpersonal skills, being responsible, self-esteem, following rules and laws, not being easily tricked or taken advantage of.
makes sense.
And then practical skills, that's the real hands-on stuff. Activities of daily living, dressing, eating, hygiene, also instrumental daily living skills like managing money, taking meds, shopping, making meals, using phones.
Right, the practicality.
Yeah, and occupational skills if relevant, and just maintaining a safe environment.
And how delayed do these skills need to be for an ID diagnosis?
The definition requires a significant delay in at least one of those three areas: conceptual, social, or practical.
Just one. Why not all three?
Well, the thinking is that people with ID can have different patterns of strengths and weaknesses. Someone might struggle more practically but have relatively better social understanding, for instance. So needing deficits across the board might miss some people.
Okay, that makes sense. It's not monolithic.
Yeah.
But you mentioned earlier, or the text did, some controversy around adaptive behavior.
Yeah, it's interesting. There's some debate about, well, is this criterion really essential for the diagnosis itself, especially for those with a very low IQ, say below 50?
Because their adaptive skills are almost always impaired anyway.
Exactly. In those cases, it might seem a bit redundant. Where it seems most useful is in confirming ID for individuals whose IQ scores fall in that kind of borderline range, maybe 60 to 75.
Oh, okay.
It really underscores this shift away from just relying on an IQ number, especially given historical concerns about, potential biases in testing and overdiagnosis. It brings in that real-world functioning piece.
So it's like a reality check almost.
Precisely. It helps make sure someone isn't labeled just based on a test score if they're actually coping okay in daily life.
Hmm.
It's also noted, though, that you can see adaptive behavior issues in other conditions, like autism or ADHD. But the reason for the deficit is different. In ID, it's more tied to the overall cognitive limitations, whereas in, say, ADHD, it might be more about executive function problems.
Okay.
And the text also questions if those three domains, conceptual, social, practical, are truly independent. Research hasn't fully backed that up yet. And importantly, we need to distinguish adaptive deficits from maladaptive behaviors like aggression. They aren't the same thing.
Right. Good point.
Right.
Okay, so that's adaptive behavior. What about the intellectual function part? What IQ score generally points to a significant impairment.
Okay, so significant impairment in general intellectual function is usually defined as an IQ score about 2 standard deviations below the average.
And the average is 100.
Right. On most standard tests, the average is 100, and a standard deviation is 15 points. So 2 deviations down generally means a score below 70.
Okay, below 70.
Yeah. But, tests aren't perfect.
Yeah.
There's always a margin of error, what they call the standard error of measurement. So if you account for that, the upper limit might stretch up to about 75.
So 70, possibly up to 75, but you still need the adaptive functioning piece.
Exactly. That adaptive skills requirement helps prevent false positives, especially if using that slightly higher cutoff. And it's important to remember, kids with ID often have uneven profiles. They might have some strengths, some weaknesses. Not all their subtest scores will necessarily be below 70.
Got it. And you mentioned the age of onset earlier, before 18 to 22. Why is that cutoff so important?
It's really about distinguishing these developmental conditions from disabilities that might happen later in life, like from a traumatic brain injury or a stroke.
Ah, I see.
Even if the formal diagnosis happens after 22, the underlying challenges in thinking and adapting must have been evident before then. It also has implications for accessing certain services.
Okay. And is ID something that gets progressively worse over time?
No, the medical text is very clear. Intellectual disability is non-progressive.
Yeah.
People with ID do continue to learn and gain new skills, just typically at a slower pace than their peers. You might see the rate of progress slow down as they get older, but that's different from regression.
Regression being losing skills they already had.
Exactly. Regression is a major red flag. If a child starts losing skills, you need to investigate for other potential underlying causes, maybe metabolic disorders, neurodegenerative conditions, things like that.
Right.
Though sometimes regression can happen secondary to other issues, like if a child with cerebral palsy loses mobility because spasticity increases or language declines when new seizures start. But the ID itself isn't worsening.
That's a really crucial distinction. Slower progress versus actual loss of skills. Okay, now what about global developmental delay, or GDD? We hear that term a lot, especially for younger kids. How does that fit in?
Right, GDD. That term is specifically for children under the age of 5. It means they have significant delays defined as more than 2 standard deviations below the average in reaching milestones in at least 2 developmental domains.
And those domains are?
Things like language, motor skills, cognition, social or personal skills, and activities of daily living. Usually, if there are delays in 2 areas, it suggests broader delays, including cognitive ones.
So is GDD basically like an early warning sign for ID?
It often is, yes. Many kids diagnosed with GD do continue to face challenges, maybe around 80% according to some studies mentioned. And this is important, not all kids with GDD will go on to meet the criteria for ID later.
Yeah.
Well, a few reasons. Developmental testing in very young kids isn't always as predictive as testing in older children. Sometimes kids catch up a bit with maturation or intervention. Sometimes they get reclassified later with something else, like autism or a specific language disorder. Or maybe the initial GDC diagnosis wasn't quite right.
Okay.
And sometimes, confusingly, the term GDD might still be used for kids older than 5 if their delays were really significant early on, even if they technically meet ID criteria.
So GDD is more like a placeholder diagnosis for the under 5s.
Kind of, yeah. It's a descriptive term for significant early delays. And the text also makes an important point distinguishing this medical diagnosis of GDD from an educational classification.
How are they different?
The medical GDD diagnosis needs delays in at least 2 domains, like we said, but the educational classification of developmental delay, which falls under the IDEA law.
IDEA being the Individuals with Disabilities Education Act.
Right. Under IDEA, a state education agency might classify a child as having a developmental delay if they have delays in just one domain, if that delay means they need special education services.
Ah, so the educational category can be broader.
Exactly. And the specific rules for that educational classification can even vary from state to state. So for parents, it's good to know there might be different criteria depending on whether you're talking to a doctor or the school system.
That's a really helpful clarification. Okay, so we have ID defined by intellectual and adaptive limits, starting before adulthood, and GDD for young kids with delays in multiple areas, maybe leading to ID, maybe not. Now, why? What causes these developmental differences?
Well, the sources list a whole range of potential causes, acting at different times: prenatal, during birth, postnatal, early childhood.
Like what?
Things like infections, trauma, complications from being born too early, lack oxygen, exposure to toxins like alcohol or lead, metabolic problems, endocrine issues, severe malnutrition, and importantly, a wide variety of genetic abnormalities.
Wow, a lot of possibilities.
It is. And what's striking is that for many individuals with ID, especially milder forms, finding a specific cause just from their history and physical exam can be really difficult.
Which is where more testing comes in.
Exactly. Further medical and increasingly genetic evaluation is often needed.
And genetics is playing a bigger role now.
Definitely. The text highlights how genome sequencing is identifying more and more genetic causes. Now, while there are over 100 known treatable metabolic disorders that can cause ID,
Treatable, that's important.
very important, but those actually account for a pretty small percentage of all ID cases overall.
Okay.
Still, trying to find an underlying cause and etiologic diagnosis is incredibly valuable.
Why is finding the specific cause so important?
Several reasons. It can tell you about potential associated medical issues like seizures or heart problems. It gives clues about the prognosis, maybe life expectancy. It helps families understand the risk of it happening again if they have more children. It can provide a sense of validation or closure for the family. It might unlock access to specific services or support groups. And longer term, understanding the cause helps research into potential future treatments. Families almost always want to know why, if possible.
That makes total sense. Knowing why can change a lot. The text also mentioned different risk factors depending on the severity of ID.
Yes, there seem to be some patterns. For mild ID, non-genetic risk factors are often prominent things like low socioeconomic status, lower maternal education, living in a developing country, malnutrition, poor healthcare access.
So more environmental or social factors.
Often, yes, though biological factors like intrauterine growth restriction, prematurity, birth complications, prenatal substance exposure, lead exposure, some sex chromosome issues, and certain genetic syndromes can also contribute to mild ID.
Okay, and for more severe ID.
That's more often linked to major genetic events. Things like chromosomal disorders, Down syndrome being a common example, or specific deletions or duplications of chromosome parts. Also, other genetic syndromes like Fragile X or Rett syndrome, significant brain development abnormalities, and those inborn errors of metabolism we mentioned.
So bigger biological hits, often genetic.
Generally, yes. Even severe ID without a known syndrome can result from inherited or brand new single-gene mutations or tiny genetic deletions or duplications. The text mentions over 1,300 individual genes have now been associated with ID.
Wow, 1,300?
Yeah, and a general rule of thumb is the earlier in development the problem occurs, the more severe the impact tends to be.
Okay, so causes are incredibly varied. Let's talk about diagnosis. How do doctors figure out if a child has developmental delay or ID? What's the process?
It's usually a comprehensive approach. It starts with a really detailed history, pregnancy, birth, developmental milestones, any medical issues, and a thorough family history looking for similar conditions.
Okay, history first.
Then, a careful physical examination. Doctors look for any physical clues, like unusual facial features, differences in head size, limb abnormalities, what they call dysmorphisms, that might point towards a specific syndrome.
Looking for patterns.
Exactly. And basic hearing and vision screenings are essential. You have to rule out sensory loss as a cause for delays.
Right, can't learn language well if you can't hear.
Precisely. And then a core piece is the psychoeducational evaluation. This involves standardized testing of both cognitive abilities, the IQ part, and adaptive functioning skills.
The testing part. And when does genetic testing fit in? You said it's becoming more common.
It really is. The medical text even includes a table showing guidelines from groups like the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics.
So what tests do they recommend?
Chromosomal microarray analysis, or CMA, is often recommended as a first-tier test now.
CMA, what's that?
It's a genetic test that's really good at finding small missing or extra pieces of chromosomes, copy number variations that you might miss with older chromosome tests like karyotyping. It's recommended for unexplained ID, GDD, autism, or multiple birth defects.
Okay, CMA first. What else?
FMR1 repeat analysis, that's the test for Fragile X syndrome, is also frequently recommended, especially for boys with ID or if there's a family history suggesting Fragile X.
Fragile X, right.
Depending on the specific clinical picture, other tests might be considered too, like testing for specific genes, like PTN or MECC2 for Rett syndrome, or maybe a karyotype if a larger chromosome issue is suspected.
And if those initial tests don't find anything?
Then you might move to broader genetic testing. Exome sequencing, or ES, looks at the coding regions of most genes. Or even whole genome sequencing, WGS, which looks at pretty much the entire genetic code.
So levels of genetic investigation. What are the pros and cons of these tests, like CMA versus exome?
Good question. CMA is great for those copy number variations, but it won't usually find single gene mutations within a gene, or balanced rearrangements where chromosome pieces have just swapped places, or mitochondrial DNA issues.
Okay.
Exome sequencing, ES, is much better at finding those single gene sequence changes. And some labs can now detect copy number variations from exome data too. But it might not cover all coding regions perfectly, and it doesn't typically look at non-coding DNA or those specific repeat expansions like in Fragile X.
So FMR1 testing is still needed separately for Fragile X.
Usually, yes. And whole genome sequencing gives the most data, including non-coding regions, but interpreting all that information is a huge challenge.
It sounds incredibly complex. Are there specific signs during the exam that might push doctors towards certain tests?
Yes, definitely. Certain red flags might suggest specific underlying conditions. Things like those dysmorphic features we mentioned, having multiple congenital anomalies, a history of regression, losing skills seizures, or specific movement disorders. These might guide the testing strategy.
And it's also critical to rule out other conditions that could maybe look like ID, right?
Absolutely crucial. Before settling on an ID diagnosis, you have to consider and rule out other possibilities.
Such as?
Significant hearing or vision loss, obviously. Communication disorders, seizure disorders that are hard to control because ongoing seizures can impact cognition, poorly managed mood disorders like severe depression or severe untreated ADHD. Also, some progressive neurological conditions might initially present like ID before the decline becomes obvious. And it's important that ID can, and often does, co-occur with other conditions.
Like autism.
Exactly. The text mentions about a third of children with autism spectrum disorder also have ID, and about half of kids with cerebral palsy have ID.
So how do you tell them apart if they overlap?
It takes careful assessment. With cerebral palsy, the motor impairments are typically more pronounced than the cognitive ones, plus you see specific neurological signs. With autism, even if there's cognitive involvement, the core deficits in social communication and interaction are usually the most prominent feature, often more so than nonverbal reasoning skills, whereas in ID, the delays tend to be more even across cognitive, adaptive, social, and motor areas.
Okay.
And the type and intensity of restricted and repetitive behaviors also help distinguish between ID alone versus ID with co-occurring autism.
So it's a really thorough process: history, exam, testing, ruling things out, looking at the whole pattern. Okay, let's talk about what ID actually looks like day to day. How does it typically present at different ages?
It can look quite different depending on the child's age and how severe the ID is. In very early infancy, maybe under 6 months, you might see things like poor responsiveness, not tracking visually, not reacting much to sounds, or unusual muscle tone, either too floppy or too stiff. Maybe feeding difficulty.
Okay, subtle signs early on.
Then, between maybe 6 and 18 months, delays in gross motor skills often become the main concern, not sitting, crawling, or walking when expected.
Motor milestones.
Yeah. And after about 18 months, language delays and sometimes behavior problems become more common reasons parents seek evaluation.
Language really kicks in then.
Right. And for kids with milder ID, the challenges might not become really obvious until they hit school age and the academic demands increase.
Right. School highlights those cognitive differences.
Exactly. And as expectations for independence grow at home, socially through later childhood and adolescence, the limitations in mild ID can become more apparent.
How so?
Well, an older child or teen with mild ID might be able to chat about everyday topics, keep up with trends, but they might struggle with more complex reasoning, the why and how questions.
Abstract thinking.
Right. The text notes that if interactions stay superficial, their ID might not even be obvious to some people. It also mentions that stigma is a real issue, and sometimes teens might refer to their difficulties as learning disabilities instead of ID. And sadly, they are at higher risk for bullying and being taken advantage of.
That social vulnerability piece is huge. You also mentioned co-occurring conditions earlier. How common are those?
They are quite common. Children with ID have higher rates of other medical, developmental, and psychiatric conditions compared to typically developing kids.
Like
Things like cerebral palsy, ADHD, seizures, vision and hearing problems, anxiety, depression, behavioral disorders. It's a long list.
And these can significantly impact outcome.
Absolutely. The text makes a really important point that sometimes these associated conditions can actually have a bigger impact on the person's quality of life and overall outcome than the ID itself.
Wow.
And we also have to be aware of the increased risk these children face for accidental injuries and, unfortunately, for neglect and abuse as well.
That's incredibly important to keep in mind. Okay, so ID rarely exists in a vacuum. Let's shift to what can be done. What about treatment and support?
Well, the core intellectual and adaptive limits of ID aren't really curable in the traditional sense, but, and this is key, many of the associated challenges can be addressed effectively, especially if you start early.
Early intervention is critical.
Absolutely. Things like behavioral interventions and parent training are really important for managing challenging behaviors. Often, these behaviors are a form of communication, stemming from frustration or a mismatch between the child's abilities and environmental demands.
Understanding the why behind the behavior.
Exactly. And while there's no medication to improve the core symptoms of ID, medications, psychopharmacologic agents can be very helpful for managing those co-occurring conditions like ADHD, anxiety, aggression, or sleep problems.
So treating the whole picture and having a coordinated team seems vital.
Essential. A medical home, usually with a primary care clinician, is key to coordinating care, making referrals, and connecting families with specialists and therapists.
What kind of specialists?
Oh, it could be speech therapists, physical therapists, occupational therapists, psychologists, audiologists, nutritionists, plus medical specialists like neurologists, geneticists, developmental pediatricians. It really depends on the individual's needs.
A whole team approach.
Yes. And then there are the educational supports. For young kids under IDEA, there's the Individualized Family Service Plan, or IFSP.
IFSP for the little ones.
Right, focusing on the family's needs to support the child's development. Then for school-aged kids, it becomes the Individualized Education Program, or IEP, focused on their educational goals and services within the school system.
IEP in school. And the text mentioned inclusive education.
Yes, the importance of inclusion, where kids with disabilities learn alongside their typical peers in general education settings as much as appropriate. The sources note benefits for all kids involved, both those with and without disabilities.
That's great. What about other supports?
Families might be eligible for various federal and state social services, like respite care or home and community-based support waivers. Leisure and recreation are also highlighted as really important for social inclusion and well-being. And given the journey families are on, family counseling and support groups can be incredibly valuable too.
It really takes a village, doesn't it? A wide range of supports. What about as individuals with ID get older and transition into adulthood? What's important then?
That transition to adulthood is a really critical period, and planning needs to start early, often during high school.
What does that planning involve?
Key areas include decision-making support, exploring options like supported decision-making or, if necessary, guardianship. Accessing adult benefits like supplemental security income, SSI, and Medicaid. Figuring out living arrangements, independent living with supports, group homes, family homes. Also, financial planning, things like ABLE accounts or special needs trusts. Exploring options for post-secondary education or vocational training, and finding meaningful employment. And maintaining community involvement and social connections.
That sounds like a complex transition.
It can be. Services can sometimes become more fragmented after leaving the school system. That's why transition planning is mandated as part of the IEP process, starting by age 16, to help smooth that path towards employment and community life.
And the text mentions self-advocacy.
Yes. The self-advocacy movement is really important. It's about empowering individuals with ID to speak up for themselves, make their own choices, and push for full inclusion and self-determination in society. It's had a big impact on policy.
That's fantastic to hear. Okay, finally, let's talk about outcomes. What does the future generally look like for someone with developmental delay or ID?
Well, as you might expect, outcomes are really variable. They depend heavily on the underlying cause, the severity of the ID, any co-occurring conditions, and crucially, the quality and consistency of the support they receive throughout their lives.
Right.
It's interesting, the text notes that mild ID isn't always necessarily a lifelong diagnosis.
Oh, how so?
Some kids initially diagnosed with GDD might later catch up or be diagnosed with something more specific. And some individuals diagnosed with mild ID during their school years might develop enough adaptive skills as adults that they no longer technically meet the criteria, especially if the demands of their environment match their abilities.
Interesting.
Conversely, someone with, say, a learning disorder might struggle more over time and eventually fall into the ID range. It can shift. We also see higher prevalence rates in lower income countries where community-based rehabilitation plays a big role.
And what about functioning levels based on severity?
Generally speaking, adults with mild ID can often achieve a good degree of social and economic independence, maybe with some ongoing guidance or support. Those with moderate ID can usually learn vocational skills and manage daily self-care with supervision, often living in supported settings. Individuals with severe or profound ID typically need much more extensive, often lifelong, support for daily living, health, and safety.
And life expectancy.
For mild ID, life expectancy is pretty similar to the general population. But for severe and profound ID, it's often reduced, usually due to associated medical conditions like heart problems or respiratory issues. The lifetime costs associated with supporting individuals with ID are also noted as being significant.
A complex picture, definitely.
It is. And the text concludes by really emphasizing the ongoing need to improve healthcare, make that transition to adult care smoother, and ensure high-quality, integrated, community-based services are available for everyone with ID.
So it's clear that while ID presents challenges, early identification, tailored, comprehensive support, and a focus on individual strengths and community inclusion can really shape positive long-term outcomes. This deep dive has certainly clarified a lot, I think, about the definitions, diagnosis, causes, and supports getting beyond just labels.
Absolutely. It's about understanding the nuances.
It really is.
Yeah.
And, thinking about all this, especially the rapid advances in genetic testing and our growing understanding of brain development,
Yeah.
it does make you wonder, doesn't it? What new possibilities might emerge in the future for supporting individuals with developmental delay and intellectual disability and their families? Maybe new therapies, better targeted interventions. It's definitely something to keep thinking about.
A very provocative thought to end on. And hopefully, a spur for continued learning, understanding, and focus on inclusion.